Hello, welcome once again to another session of Pathophysiology and Pharmacology 1. This is a continuation of the content covering gas exchange. In our previous discussion, we talked about the pathophysiology of the respiratory system, and we also discussed some common pathophysiological processes that occur to result in disease, such as common cold and the allergic rhinitis. Today, we're going to focus on the lower respiratory tract. And so we are going to talk about asthma and COPD. We will be discussing the pathophysiological process of both disease and then talk about some of the common medications that are used to correct those pathophysiological processes. So first, let's talk about the pathophysiology of asthma. Asthma is a chronic inflammatory disease characterized by inflammation of the airways, bronchial hyperactivity, and bronchospasm. Although the cause of asthma is unknown in about 50% of the cases, the other 50% is caused by an immune response to allergies. Allergies could be allergens in the atmosphere such as pollen, dust, fumes, smoke, bedbugs, and dust mite, and other substances such as home detergent and cleaning supplies. Symptoms of asthma result from a combination of both the inflammatory process and bronchoconstriction. And so any treatment has to address both components. For a patient that has asthma or that develops asthma, you will see symptoms such as the sense of breathlessness, tightening of the chest, wheezing, dyspnea, and cough. The wheezing is as a result of the excess secretion of mucus in the respiratory tract. So now let's look at the pathophysiology of chronic obstructive disease, also known as COPD. COPD is a progressive, largely irreversible disorder that restricts airflow in the lungs. COPD is a combination of two pathologic processes, chronic bronchitis and emphysema. For an individual that has COPD, you as the nurse will see symptoms including chronic cough, excessive sputum production, wheezing, dyspnea, and poor exercise tolerance. All these are as a result of the inflammatory process. The excess sputum and production can thicken up, making it difficult for them to expectorate. This in turn increases their difficulty in breathing and causes wheezing. These symptoms of COPD result largely from the pathologic processes of the chronic bronchitis and emphysema. So let's consider what bronchitis is. Chronic bronchitis is defined by chronic cough and excessive sputum production. This results from the hypertrophy of mucus-secreting glands in the epithelium of the larger airways. So hypertrophy is just the increase in size of the glands that secrete mucus. And when they increase in size, then they also increase in the production of mucus. This mucus can thicken up, and also because there is a reduced activity. Remember when we discussed the last session we said that there are cilia lining the respiratory tract to help with the movement of mucus. So this mucus or this cilia, if they become stiffened, there is going to be reduced movement, and so it becomes difficult for patients who have COPD to cough up stuff. Emphysema is basically the enlargement of the air spaces within the bronchioles and alveoli. This is brought on by the deterioration of the walls caused by cigarette smoke. So as the patient smokes, the smoke deteriorates the spaces in between the cells, creating a deterioration of the walls between the air spaces. And this is what causes emphysema. Among individuals with COPD, the relative contribution of these two processes, which is the chronic bronchitis and emphysema, can vary depending on what their basic underlying cause is. So depending on how many years they have smoked, how long they've been exposed to smoke, and other toxins, the variety of emphysema or the percentage of the chronic bronchitis and emphysema are going to be variable. Now that we understand the pathophysiology behind asthma and COPD, let us look at some of the classes of medications that are used for their treatments. We know that both asthma and COPD are as a result of inflammation and bronchoconstriction, and COPD has chronic bronchitis and emphysema, which are all inflammatory responses to toxins. So let's look at some of the medications. Asthma and COPD treatment includes anti-inflammatory drugs and bronchodilators. These are the two main pharmacologic classes of medications or drugs that are used for the treatment of asthma and bronchitis. The anti-inflammatory drugs are going to stop or impede the inflammatory process, and then the bronchodilators are going to help the bronchi to expand so that there can be ventilation. The most common route that are used for this or these medications is the inhalation route. So why do we give these drugs by the inhalation method or route? This is because the inhalation route increases therapeutic effects by delivering the drug directly to their site of action. So we want the drugs to go into the respiratory tract and prevent inflammation and also to help with bronchodilation. So when we give it through inhalation, it goes directly to where we need it to be. This reduces the systemic effects by minimizing drug levels in the blood and also facilitates rapid relief because it doesn't have to go through the pharmaceutic phase and then the pharmacokinetic phase. Because the drug skips the pharmaceutic phase and the first pass effect, it has a higher bioavailability. So there is a higher percentage of the drug that is going to be available to act on the sites. Using the inhalation method, there are 3 devices that are used. The first one is called the metered dose inhalers. The second one is the dry powdered inhalers. And the third one is known as the nebulizers. When you are caring for a patient, you must instruct the client or the patient the correct way to use these devices. And we will be talking about this more when you begin taking your healthcare of the client courses. So a metered dose inhaler is a small handheld pressurized device that delivers a measured single dose of drugs when it is activated. There is also what we call the respimats, which deliver a fine mist when activated by the client. This is metered dose because it can be precise and it delivers just one single dose. Then you have the dry powdered inhalers, which is used to deliver medication in powder form when the client activates the device by inhalation. So with this, you will have to ask the client to draw the medication basically from the device. The nebulizer is the most common device that is used during hospital stay. It is a small device that is attached to an air supply that converts a drug from liquid solution to a mist, which can be inhaled by the client. And when using this, you can just use what we call hospital air. There has to be an air source to be able to help it to convert this liquid solution into a mist. So, let us now focus on the classes of medications that are used for asthma and COPD. We will first begin by discussing anti-inflammatory drugs. Anti-inflammatory drugs are the foundation of asthma and COPD therapy. Because they are long-acting and they are long-term, they are used for maintenance of asthma and COPD. These are drugs that the client will take every day for long-term control of both disease. So let's look at some examples or subclasses of anti-inflammatory drugs. The first one we will be looking at is glucocorticoids. Glucocorticoids reduce symptoms of asthma by suppressing inflammation. They decrease the synthesis and release of inflammatory mediators such as prostaglandin and reduce infiltration and activity of inflammatory cells. By doing so, they decrease the edema of the airway mucosa caused by beta agonists. There are inhaled and oral forms of glucocorticoids. The inhaled forms are used for long-term prophylaxis of asthma. It is not for aborting an ongoing attack. That means if a person is having an ongoing attack, you cannot use a glucocorticoid because it's not going to be effective immediately. It takes a long time for it to become effective. Therefore, glucocorticoids must be administered on a fixed schedule, not PRN basis. Unless the asthma is very severe, glucocorticoids should always be administered by inhalation. Inhaled glucocorticoids generally are very safe, and their principal side effects are oropharyngeal candidiasis and dysphonia, which can be minimized by using a spacer device during administration and by gargling water or rinsing the mouth after each use. So oropharyngeal candidiasis is a fungal infection, that causes patches in the mouth. And you as the nurse will have to take care of this by giving them salt water to gargle their mouth with. The use of any alcohol-based mouthwash is not recommended when a patient has sores in the mouth. Glucocorticoids also come in the oral form. For patients with moderate to severe persistent asthma or for management of acute exacerbations of asthma, an oral glucocorticoid can be used. There is, however, a potential for toxicity, and so it should be used only when symptoms cannot be controlled with a safer medication, such as inhaled glucocorticoids or inhaled beta agonists. Treatment should be as brief as possible. This is because prolonged therapy with oral glucocorticoids can cause serious adverse effects, including adrenal suppression, osteoporosis, hyperglycemia, peptic ulcer disease, and even growth suppression in children. So for osteoporosis, you as the nurse will encourage the client who is taking these classes of medications to increase muscle strength exercises, which will increase the bone strength, and also to take vitamin D and calcium. For hyperglycemia, you as the nurse will do the intervention of assessing blood glucose levels frequently, which is normally between 4 to 6 hours, and then treating any high blood sugar with insulin. Also, you want to encourage patients to take this medication with food to reduce gastric irritation and also to prevent ulceration in the stomach, which is the peptic ulcer. And for growth suppression, this shouldn't be used in children who are below 14, and also it has to be used briefly to prevent any growth suppression. Because of adrenal suppression, patients taking oral glucocorticoids or patients who have switched from oral glucocorticoids to inhaled glucocorticoids must be given supplemental doses of oral or intravenous glucocorticoids at times of stress, such as times of illness, exacerbations, or if they are undergoing any psychosocial stress such as depression, anxiety. During these times, the provider must give supplemental doses of glucocorticoids. Another thing with adrenal suppression is that you cannot stop this medication abruptly, because the adrenal glands normally produces glucocorticoids that the body needs. When you are taking external glucocorticoid drug, the adrenal glands decrease their production of glucocorticoids, and they are pretty happy that this drug is performing their function for them. And so, when you stop glucocorticoids abruptly, there will be an inadequate amount in the bloodstream due to the suppression or as a result of the suppression. Therefore, glucocorticoids should be tapered down before they are stopped. So if I am a patient who is taking a glucocorticoid, say 50 milligrams, my provider is not going to stop it abruptly, but she or he may reduce it to 30 milligrams and then maybe 20 to 10, 5 for some days before I can stop it completely. This is very important in order not to cause adrenal insufficiency. So you have to notify the provider if they by mistake stop this medication abruptly, or you have to educate also the client not to stop this medication abruptly. The next class of medications that we will be looking at are called leukotriene modifiers. Leukotriene modifiers promote smooth muscle constriction, blood vessel permeability, and inflammatory responses through direct action and recruitment of eosinophils and other inflammatory cells. And so what leukotriene modifiers do is they reduce bronchoconstriction and inflammatory responses such as edema and mucus secretion. Leukotriene modifiers are not first-line therapy. There are three forms or three options of this type of drug that are available in oral forms. Generally, they are very well tolerated, but they can also cause some adverse reactions and neuropsychiatric effects. The neuropsychiatric effects include depression, suicidal ideation, and suicidal behavior. So first, let's look at the first example of leukotriene modifiers. This is known as Zyflo. Zyflo inhibits leukotriene synthesis, thereby stopping the inflammatory process. Zyflo can be taken with food or on an empty stomach, and it undergoes rapid absorption, and so its effectiveness or its time of action is shorter. The liver metabolizes Zyflo and is excreted by the kidneys in the form of urine. So if there is an overdose or any adverse reaction, we have to also be monitoring the liver and the kidneys to make sure that there is nothing going on over there. Adverse effects of Zyflo include liver damage. So you will see symptoms of hepatitis or symptomatic hepatitis, and this will be identified by increases in AST and ALT, both of which are produced in the liver. We've already talked about the neuropsychiatric effects, but you should monitor for depression, anxiety, hallucinations, and suicidal ideation for the client who is taking Zyflo. Zyflo can also interact with other drugs. Zyflo will increase the levels of theophylline, warfarin, and propranolol. We will talk about theophylline in this presentation, but warfarin is an anticoagulant which is used to prevent blood clots. And so Zyflo is going to increase the levels of warfarin in the blood, which means that the patient will be at an increased risk for bleeding. Propranolol is a beta blocker which is used to control high blood pressure and also to control the heart rate. So if Zyflo is going to increase the levels of propranolol, this means that the patient is likely to have hypotension, which is decreased blood pressure, or bradycardia, which is decreased heart rate. And so we should be monitoring that. The provider will have to adjust the levels of these medications to suit the client who is taking Zyflo. The next drug that we are going to talk about is known as Accolade. Accolade is a leukotriene receptor antagonist, and it reduces infiltration of inflammatory cells and thereby reduces bronchoconstriction. This medication is taken orally and should be taken on an empty stomach. And when we say empty stomach, we mean 1 hour before meals or 2 hours after ingestion of food, because food reduces its absorption. The side effects of accolades include headache, GI disturbances, irritation, and it also has an adverse effect on the liver because it causes liver damage. Accolade can also interact with other drugs. For example, it increases the levels of theophylline and warfarin. So, as you are studying, be paying attention to the similarities among the examples in all these drug classes and note what are different. So we have known, or we have just realized, that both accolade and Zyflo are going to increase the levels of theophylline and warfarin. However, Zyflo also increases the level of propranolol. So be mindful of that. The third option of leukotriene modifiers is Singulair. Singulair blocks leukotriene receptors by attaching to the receptors in the airway and pro-inflammatory cells such as eosinophils. It cannot be used for a quick relief of symptoms because its effect develops slowly. That is why these are second-line drugs. Singulair has some adverse effects, but there are no major side effects which has been identified as at yet. However, an adverse effect can be what is called Church-Strauss syndrome. This is symptomized by weight loss, flu-like symptoms, and vasculitis. So once you start seeing this, the client has to be evaluated for adverse toxic levels in the blood. There are also some drug-to-drug interactions. Singulair decreases in effect when a person is taking phenytoin. So phenytoin is an anti-seizure medication. It's also known as Dilantin. So Dilantin would decrease the effect of Singulair. And so if a patient is taking Dilantin, then the levels or the dosages of Singulair has to be increased for you to have the minimum effective concentration. Now let's look at another class of medications for anti-inflammatory drugs. These are known as cromolyn. Cromolyn is an inhaled anti-inflammatory drug that is used for prophylaxis asthma treatment. Cromolyn reduces inflammation primarily by preventing the release of mediators from mast cells. For long-term prophylaxis, cromolyn is taken daily on a fixed schedule, just like the glucocorticoids. Cromolyn is one of the safest drugs for asthma because there are no known serious adverse effects. The only side effects that are associated with cromolyn is cough, and also a patient can develop bronchospasm from the use of cromolyn. The other type of anti-inflammatory drug is Xolair. Xolair or omalizumab is a unique medication in that it is an antagonistic of IgE. This is a type of antibody in the body system. It is used in clients who are 12 years or older who have moderate to severe asthma. That is allergy related and cannot be controlled with inhaled glucocorticoids. So for you to qualify to use Xolair, you must be first of all 12 years or older. Your asthma should be allergy related, and you have to have uncontrolled asthma. That is, your asthma is not controlled by glucocorticoids. This is because this treatment can be expensive. It can cost more than $10,000 a year. The solution, which is viscous, is administered subcutaneously. So this is a subcute treatment. Adverse effects include the injection site reactions, so skin reactions such as itchiness, swelling, viral infection because it decreases the immune system's ability to respond to the inflammatory process, thereby reducing the body's ability to fight off infections. And so you will also see an increase in upper respiratory infections as an adverse effect. Sinusitis, headache, pharyngitis, and sometimes cardiovascular events such as increased heart rate or tachycardia. Cardiovascular events may also be as a result of the other processes that are going on, such as your pharyngitis and headache, which can cause an increase in blood pressure. And if the patient is allergic to the chemical components of this medication, that can result in an anaphylactic reaction. The next class of medications that we are going to talk about are bronchodilators. So we have been talking about anti-inflammatories. So now we are going to talk about bronchodilators. Bronchodilators provide symptomatic relief in patients with asthma, but they do not alter the underlying cause or process of inflammation. So this is just for a rapid response to an attack which is ongoing. But they also use in COPD patients to help decrease respiratory distress. In almost all cases, patients taking a bronchodilator should also be taking a glucocorticoid because glucocorticoids are used for maintenance and are used for long-term suppression of inflammation. The principal bronchodilators that we know of are beta adrenergic agonists or beta 2 adrenergic agonist. Beta 2 adrenergic agonists promote bronchodilation by activating the beta 2 receptors in bronchial smooth muscles. Beta 2 agonists, however, have a limited role in suppressing histamine release in the lung and increasing ciliary motion. So the cilia that lines the respiratory tract, these bronchodilators increase their motility, which is the movement, and this can cause any fluid that has been built up, such as mucus, to be transported up so the patient can cough it up or spit it out. There are inhaled short-acting beta agonists that can be used. So the inhaled short-acting beta agonists are taking PRN to abort an ongoing attack. This means that the patient takes this when it is needed. When it's not needed, the patient does not take it. It is also taken before exercise to prevent an attack. So if you have, say, a teenager, let's say a 13, 14-year-old that plays sports, they can use beta adrenergic short-acting medications to prevent an exercise-induced attack. Hospitalized patients who are undergoing severe acute attack also use the nebulized form of short-acting beta-2 adrenergic medications because that is the traditional treatment of choice. Delivery with a metered dose inhalation device in the outpatient setting may also be equally effective. However, the nebulizer, as I mentioned earlier, is the preferred mode of delivery in the hospital. There is also the second type of beta adrenergic agonist, which is the long-acting beta-2 agonist. Long-term or long-acting beta-2 agonists are used for long-term control in patients who experience frequent attacks. When used to treat asthma, it must always be combined with a glucocorticoid. So these long-acting beta-2 agonists are not a substitute for glucocorticoids, but these are used in conjunction with glucocorticoids to minimize the occurrence of attacks. It is contraindicated for a provider to prescribe or use beta-2 adrenergic agonists, which are long-acting, as a maintenance drug without any form of glucocorticoids which are added to it. The inhaled forms of beta-2 adrenergic agonists rarely cause systemic side effects. However, excessive dosing with oral beta-2 agonists can cause tachycardia and angina, which is chest pain, by activating beta-1 receptors on the heart. Remember, we talked about selectivity. So just as histamines, we have 1 and 2, we also have beta 1 and 2 agonists. Beta 1 is found mainly in the heart muscle, and so if the drug is used in higher doses, they lose their selectivity and may activate beta 1 receptors, which may cause chest pain. The inhaled form of long-acting beta adrenergic medication can also increase the risk of asthma-related death but only when used incorrectly. So to reduce the risk of this, it should be used only by patients taking an inhaled glucocorticoid for long-term control, and only if the glucocorticoid has been inadequate in itself. The next line of medications for bronchodilators is the methylxanthines. Examples include theophylline and aminophylline. So look at the ending of the methylxanthines. They all end in PHYLLINE. And this is how you can group your learning. Let's look at the first one, theophylline. Theophylline produces bronchodilation by relaxing smooth muscles. Although theophylline was used widely in the past as the first line of medication, it has been largely replaced by safer and more effective medications. This is because theophylline has a narrow therapeutic index. So think about when we talked about pharmacodynamics and pharmacokinetics. If a drug has a narrow therapeutic index, then it means we will have to monitor closely because it can be toxic. So toxicity is related to increased theophylline levels that are greater than 25 or 20, depending on what system you are using. The drug is usually administered by mouth, but may also be administered by the IV route. If it is administered by the IV route, think about the pharmacodynamics. The effects are going to be much more difficult to reverse. And so the preferred route is the oral route, which is by mouth. Methylxanthines are used in both asthma and COPD. And oral theophylline was previously used as a maintenance therapy of chronic stable asthma. But as I said, because of the short therapeutic index or the narrow therapeutic index, it is now considered not to be as safe because there are many other options. Plasma levels above 30 micrograms per milliliters causes severe dysrhythmias such as ventricular fibrillation and convulsions, and death may result from cardiorespiratory collapse if it is not reversed immediately. So once you begin to see the mild symptoms of nausea, vomiting, diarrhea, insomnia, and restlessness, then you should be reporting these symptoms if you know that the patient is on theophylline. So the provider will be able to evaluate and see what is going on. Okay. If toxicity occurs during treatment, then you have to stop the theophylline, give the patient activated charcoal together with a cathartic. And then with dysrhythmias, the provider is going to respond by giving lidocaine, which will reduce the contractility of the heart muscle. Intravenous diazepam, which is an anti-seizure medication or a benzodiazepine, will help to control the seizures. There are also many interactions that occur when a person is on theophylline. So remember when we talked about Zyflow and we talked about allocate and all those medications. We said that it increases the levels of theophylline. So you have to be careful when a patient is on this medication. Caffeine also interacts with theophylline because it exacerbates the toxic effects, which includes the restlessness, the cardiac symptoms, and also this can cause tachycardia. The use of tobacco and marijuana is also prohibited because it can interact with the medication by increasing the side effects. And then cimetidine is an antihistamine or anticholinergic that can also increase the possibility of anticholinergic effects. And some antibiotics, such as the fluoroquinolone, can also be affected if a person is taking theophylline. The last set of medications that we are going to be looking at is the anticholinergic drugs. So anticholinergic drugs improve lung function by blocking muscarinic receptors in the bronchi, thereby causing bronchial dilation. And there are various forms of anticholinergics. These includes your ipratropium or Atrovent. You have the Spiriva, and also you have the other forms which are not commonly used, but they are all available on the markets. But the ones that you will see commonly are your Atrovent and Spiriva. The action of anticholinergics is the relief of bronchospasm. So, for example, when delivered by inhalation, inhaled anticholinergics would arrest the physiological process The next line of medications that we are going to look at are anticholinergics. Anticholinergic drugs improve lung function by blocking muscarinic receptors in the bronchi, thereby causing bronchial dilation. Some of the prototypes of this type of medication or this class of medication that we have are Atrovent or ipratropium, tiotropium, and which is also known as Spiriva. Atrovent is an atropine derivative, and this is administered by inhalation to relieve bronchospasm. Spiriva, on the other hand, is a long-acting inhaled anticholinergic agent, and it is approved for use as a maintenance therapy of bronchospasm associated with COPD. So you are going to see Atrovent more often in the clinical setting. Ipratropium is administered by inhalation, and the therapeutic effect usually begins between 30 seconds or within 30 seconds, reaching its maximum potential or effectiveness within just a few minutes. So within about 3 minutes, it is going to be 50% of its maximum effectiveness and persists for about 6 hours. And so you're going to see this being ordered every 6 hours, and sometimes it can also be ordered PRN. The adverse effects of anticholinergics include dry mouth. So just remember this: can't see, can't pee, can't spit. Okay, your mouth becomes dry, and this causes irritation of the pharynx, and also it affects the eye, and so it can exacerbate the symptoms of glaucoma. There are also cardiovascular effects such as tachycardia that can also result from the use of impratropium. Tiotropium is long-acting and is an anticholinergic agent which is approved for maintenance therapy, as I mentioned. This is not approved for asthma. It is only used for or approved for COPD. And it relieves bronchospasm by blocking the muscarinic receptors in the lung. The therapeutic effects begin about 30 minutes, and so this is not a rescue inhaler. 30 minutes after inhalation and peaks in about 3 hours and persists for about 24 hours. And so with subsequent doses, bronchodilation continues to improve, reaching a plateau after about 8 consecutive doses, which will be basically 8 days of use. The good thing about tiotropium as compared to the impratropium is that it has minimal anticholinergic effects. However, it still can cause dry mouth. And so the way to resolve dry mouth is to ask the patient to chew some hard candy, to hydrate frequently by drinking lots of water, if that is not contraindicated. Other anticholinergic drugs include aclidinium, and this is the newest long-acting anticholinergic for the management of bronchospasm associated with COPD. And it relieves bronchospasm just like all the other ones by blocking muscarinic receptors in the lung. Peak levels have occurred within 10 minutes of drug delivery, and so it is widely thought that the peak or the maximum effect occurs anywhere after 10 minutes. It is intended only for maintenance therapy and not as a rescue medication, and so must not be used for acute symptom relief. Adverse effects include headache by causing constriction, and also nasopharyngitis, which is an inflammation of the nasal passage and pharynx. There can also be cough that results from the use of this medication. When we are taking care of an asthma patient, we have to be using certain tests, and this course does not really focus on the management aspect because we just want to know about the drugs. But I'll just say that for management of asthma, we should be measuring lung function by measuring the ventilatory perfusion and all that, so we can assess what is actually going on and then recommend to the provider as to what medication will best. So treatment goals in the stepwise approach to asthma therapy becomes more aggressive as impairment or risk become more severe. And so we are going to begin with glucocorticoids, which are maintenance drugs, and then we will use our beta adrenergic medications as rescue. So an example of a beta adrenergic is going to be your albuterol. However, there are many forms of combinations of beta agonists and anticholinergics. And so the effects are going to be the same, reducing bronchoconstriction and bronchospasm, but the side effect will be the side effect of both medications combined, or sometimes combining medication also decreases the side effect in each individual medication. So as we talked about adverse effects and drug-drug interactions, it may help reduce some of the side effects. This brings us to the end of our discussion on the drugs that are used for asthma and COPD. The goal was to cover this in an hour, so you are not sitting behind a computer for long hours listening to this. Once again, thank you for listening, and I hope you use this to prepare for class and to prepare for the in-class activities, so that our class will be more engaging, and so that we will be able to apply what we have learned in the classroom. So see you in class and have fun.